Thank you. First, a word of apology for my abject incompetence in French. I'm terribly sorry. I should, having come to Montreal 6 years ago, I should now be completely fluent. But of course, I spend 2 months of every year in Montreal, and that's at McGill, where you have to negotiate quite hard to speak French. So the second apology is about the title, and explaining what's difficult about the title might help to explain where this is all going. The theme is really about communities mobilizing. When we talk about community mobilization, we have this imagery of we're going to do it. We're going to go out and we're going to mobilize these communities, and things pop up like education, and we're going to educate the communities, and we're going to advocate, and we're going to do marketing and sell something. You'll see that this is not really the tonic. The tonic begins from the sciences of participatory research. And so, framed another way, and this is the simple message for those who've got other things to do later, so you're not missing anything. The simple message is that participatory research is far more relevant today than we seem to be giving credit for. And that's the sense of my argument. It is a complex argument in that we're not talking about a new vaccine where you do your lab work and then roll it out and it works well. So the issues that I'll end up addressing, that I want to talk about today, are big picture issues, big problems. Gendered violence, vector spread, vector in the sense of mosquito-borne diseases, age-related loss of function, dementia, suicide, youth suicide. And you can say, well, what's common about these? Well, what's common about these in this presentation is that these are the things that we work on, my team works on. We're not specialists in any one of them, but we're specialists in the social infrastructure of trying to change them, what we call participatory research. I'll go through them one by one. Youth suicide, it's a massive problem. Third biggest cause amongst young people 15 to 24. Half of all of those who do complete suicide, and this is not a tiny number, half of them have a direct relationship with somebody who committed suicide. In other words, there's a contagion, something like an infection. There are other risk factors that we know about. Exposure to sexual violence, exposure to physical violence. We know these things. But what are we doing? Who's doing what? When I went to medical school, we didn't have 1 minute on how you deal with suicide, much less how you prevent them. I spent my early career in the London School of Hygiene and Tropical Medicine. Not one person working on prevention of suicide. I spent the next 35 years working around different schools of public health. One researcher here or there. Whose problem is it? Who's going to deal with this and how? Gendered violence, just about the same thing. This is hugely common. We don't even know how common. We do know that if you interview women by the age of about 30, 1/3 of them will have experienced gendered violence. What about the boys? Nobody asks the boys. In our work from Southern Africa, across 10 countries, up to the age of 14, sexual violence of boys was more common than sexual violence of girls. In South Africa itself, it took our work, which was a huge study, over 300,000 young people answered, to change the legislation so that boys could actually report rape. It was impossible in the legal code to put rape next to a male victim. It was called aggravated assault. In that setting, how are we going to get anywhere closer to it? What we know about is punishment. And what we read about is punishment. It's good. I mean, these are rotten people who do it. But it's not going to prevent it. Whose job is it to prevent it? And my concern is that I had no training, no background. But this is a really important thing because it's not just the event. It's what happens to those people for the rest of their lives. And just about everyone they know. It's really important. What are we doing about it? Age-related loss of cognitive function, dementia, getting a lot of press because we now know that this is something doubling every 20 years. At the moment, we have something like 50 million people in the world estimated. I don't know how they counted them, but about 500,000 in Canada, officially, legally diagnosed with dementia, and doubling every 20 years. We know a lot about syndrome management, but whose problem is prevention? And what we do to prevent? We hear about aluminium, we hear about toothpaste, we hear about viruses. We don't have a clue. We're not getting any closer. Maternal mortality, not so much of an issue in Canada, but a really big issue internationally. And it's got several aspects to it. The first, in my book, is this dramatic, almost virulent medicalization of pregnancy. Pregnancy gets declared to be an illness, to be handled by doctors in medical facilities, and the rest of the community, the elders, the spouses, pushed to the side. All traditional resources lost, the medical resource front and center, and of course completely inadequate to deal with the issue. Because a lot of what is behind this is not medical. It's deeply social. So if we're not doing anything about that, what are we going to do? And whose job is it to do it? Because the overworked nurse practitioner in a clinic in a rural area is not going to have a chance to work on social determinants. Then whose job is it and who's going to do it? The now much spoken of vector footprint. So this is the distribution of dengue and dengue-carrying mosquitoes around the world. They go together with several others, dengue, chikungunya, Zika. It's now rising up, coming to a city near you, coming up through the United States. There are more viruses getting recognized, more vectors. It's not getting narrower and narrower, it's getting more and more. Up to now, we've spoken about control and invested in pesticides. I say spoken because after 40 years of pesticide use, there are more types of mosquito, more viruses than there were when we started the pesticide. So talking about control. Of all of those, all of that experience with pesticide, it's sort of almost an oversight conceptually that not one study has ever shown reduction of transmission of the virus using pesticide. The way it works is rather that if you have a mosquito on your hand, you can kill the mosquito. My doing that does nothing about transmission. And our question here, as we're looking at this, is slightly fuzzy. I'm not quite sure why. So this is the state of the two big vectors for those three diseases coming up through the United States. This is for Aedes aegypti, and this is for albopictus. slightly more flexible, slightly more urban friendly. Do you notice anything around here? No walls coming to a city near you. You see, this is the thing. 30 years ago, it was these little orange dots. And every 20 years, another 3 or 4 states up. It's moving. Both of these breed in clean water. Fortunately, there's no clean water around here. Not true. Canada's got more clean water for these vectors than anywhere else in the world. They need 12 days to hatch, another 12 days to get infected. So if you don't know anything about these diseases I mentioned, dengue, Zika, chikungunya, just wait, because in 15, 20 years' time, you'll have a lot of personal expertise. But between now and then, who's going to do what about this historic environmental mismanagement that we're watching here? Whose job is it? If I am a specialist in participatory research, what's that got to do with me? Well, it's got to do with me because it's coming to get you. The issue here is that we've got these big problems. I'm concerned that I can't do anything about them, but I feel I should be. If we look at services, we're increasingly seeing that we even redefine coverage and words like universal. English is a bit like French. Universal should mean universal. But in the great wisdom of pragmatism, universal gets redefined as sometimes 80%, sometimes 90%. Can we pretend that the ones who are left out are just a random sample? Well, no, of course not. Because the ones who are left out after the so-called universal coverage are exactly the ones that need the coverage. If we look at all these new pop solutions, big data, AI, I'm in the Department of Family Medicine. We just appointed a specialist in AI. Okay, don't ask me, I wasn't on this. Okay. But ask what that's going to do. A specialist in AI, a specialist in big data, blockchains, all of this really cool stuff. What's that going to do for the people who don't have Twitter accounts, who don't have Facebook, who don't have bank accounts, who can't speak English and French, who come from somewhere else? It means nothing. There is no engagement. So how do our research philosophies derive from this peculiar distortion? So I'm a professor, I've got a white coat, that entitles me to an hypothesis, and I'm here to investigate my hypothesis. Okay? I think there must be an intervention, so I feel which way the wind blows, very scientifically suck my thumb, and say, we're going to do this intervention. And we're going to test it formally to prove that it works. You'll see that I'm trying to raise a level of cynicism about whether this model of research is going to get us any closer to those problems I mentioned. Because my experience is that it won't. There was an interesting breakthrough in this thinking about research published by Tom Frieden, New England Journal of Medicine, not long ago. It got a bit of discussion and then, like everything, faded away. But his basic proposal was that the things that individuals will get motivated on, high blood pressure, diabetes, my high blood pressure, not yours, mine, I'll be motivated on. And when I get motivated, and I invest, things can change. I can control my diabetes. And so there's a whole series of things like that where there's increasing individual effort, but they affect relatively few people and relatively few conditions. On the other hand, as you increase the impact of the interventions to cover everybody and to cover the biggest problems, the things I was talking about, our large problems, it gets less involved, or our technology and our way of doing things is more disengaged. And we might talk about things like aerial spraying and public health policy about water and all of these very general, vague things. So as we have a possibility of a bigger impact, we're actually achieving less. So the question that bridges me in here is, where do we look about getting that change and that engagement at the individual level applied to the big time level? And there's this concept that you'll know about from another domain, from neurobiology, called executive function. So executive function basically thought to reside round about here and control a whole lot of what we call lower brain functions. Where you would have heard of it is that when people talk about Alzheimer's, they talk about the loss of executive function. It's the thing that when these plaques form and you make these pretty pictures, it means that things have changed irreversibly and executive function is lost. Let's look at that executive function. There's a broad agreement now across a lot of schools that there are three broad categories, and they call different things in different texts, but three broad categories. The first is a balance between inhibition and exhibition. It's a control function, judgment function. The second is working memory, sometimes called active memory. And the third is the ability to innovate, cognitive flexibility. So those three things are what's happening when that hypertensive, me, when I was hypertensive, chowed down and decided to control my condition. That's what happened. I did those things. So here we come to an interesting possibility, dramatized by a blank screen. What if we can put these things together? Let's look at the case of arbovirus. So this study published in the British Medical Journal for 2015 about control of dengue. The thing that was interesting about this study in two countries was that it looked at vectors, it looked at serology, and it looked at knowledge and behavior. And across all of those domains, this became the first study ever to prove a change in infection rate. There have been over 1,000 studies to show that when you smack a mosquito, the mosquito dies. If you poison the mosquito dies. It's not the same. Our objective here is not just that the mosquito dies. Our objective is to interrupt infection. And in 20 years' time, when you remember this from your aching bones, when you get dengue for living in Montreal all your life, you'll remember that it's actually the infection we're trying to stop. The mosquitoes will find their way. So what made this study work? The study was called Camino Verde, Green Way, because it was looking for a pesticide-free solution. Multi-country. It was characterized by what was then said, was then spoken about. Remember, this thing went back 8 years before the publishing date. So we're talking history as far as modern studentdom is concerned. Something called community-led intervention. Communities developed their own interventions following a protocol. And the protocol was very precise. The protocol convened community groups, It shared evidence with those community groups, and it encouraged them to think of something to do. The evidence was, this is how many children in the last year were infected with dengue. This is where the mosquitoes breed in your community last month. Sharing that and encouraging innovation. So, what is really the breakthrough here? Well, there's this curiosity that suddenly this isn't activity-based in the sense of we're all going to go around, we're going to mobilize the community, we're going to get rid of all of these eggs, we're going to get rid of all of these parasites, we're going to do these 42 things, and we're going to clean up. There have been, I don't think there's a country in the world that hasn't tried to do that. And I don't think that there's a country in the world that succeeded in that strategy changing infection rate. But here's something that did change infection rate. The administration, the randomization of a participation and engagement protocol. It's a very different concept to our original mindset. So when we first, it took us a lot of time to publish this because we were having all these very clever statisticians saying very clever things like, how do we know which action was effective? And our answer was, that wasn't our question. Our question was, how do we stop this blasted disease? By interacting with communities, sharing information with them, and following what they do. That was our question. It's a different question, and when we answered that question, we got a reduction in infection, parasite levels, egg levels, improved knowledge, improved attitudes. We also got a fair amount of invention of things to do. But that wasn't what we were after. We weren't trying to steal community tech and take it and sell it somewhere. We were just saying, guys, you got this problem. There it is. What you going to do? We spent $50 per community per month just providing paints to paint on walls and occasionally a football to start a football match, that kind of stuff. But everything else came from the communities. If you come back to this and you ask, so what happened to this thing that we're told works as it now starts applying to that thing? Well, what happened is that we convened groups. This is Mexico. I don't know how many people here know Mexico. Hay Mexicanos? Okay. Mexico, we say, has got 85 million governments. No one above any other. If you don't agree with what one government says, you discuss with another government. That has the great advantage of flexibility, but a huge disadvantage if you believe in military-style interventions, mobilizing communities. Nobody mobilizes Mexicans. Mexicans mobilize themselves when they decide to. We convene groups. There's no, Facebook page on a community where you say these are the community groups. You go to a community and you find who you can talk with. Sometimes it's with people at the school, sometimes it's with people at a church, sometimes it's just with people around the market, and you find people and you talk. Groups. You share the evidence. The evidence has to be good, because otherwise they don't care. Nor would you. If I came to you and I said, okay, you're living in this community in Outremer, and we've got this literature review of international literature. Whereas if I come and I say, the children living in this street, 15% of them got infected last year, and this, and this are the places where this vector grows, what do you want to do? And discuss. You can start seeing how sharing evidence is not a trivial step. Thirdly, the innovation. And here the important point is that we innovated nothing. The community groups did the innovation. So what we were effectively doing in terms of this model of freedom was lowering the center of gravity, where that type of thing, this kind of movement behind what engages people in their own problem, became socialized. A sort of a socialized executive function, if you want to put it that way. So what we had was this protocol of the 3 steps that, not coincidentally and not without calculation, mirrors the nature of executive function. And our question was, what happens when you do this? So we saw what happened in relation to dengue, and there are now a dozen or so other studies duplicating it. Very interesting results and processes in different settings. What about age-related dementia? We've got a lot of experience with drugs. You know, the drug industry is very agile. You bring a problem, the drug industry will bring drugs. Very, very, very surefire. And we've got another industry, almost as unscrupulous, much less successful in the sense that there are drugs that are good for syndrome management in relation to dementia. They don't reverse it, but make things more manageable. Cognitive therapy, basically software, you do simulation games, what they call brain training. Flat. After 20 years of pushing this, we don't have anything. There are some hints of the early stages of cognitive therapy combined with exercise where there are short-term gains. And that's good. I mean, look, the business we're in, any gain is a good gain. We just want to try and make things a little bit better, bit at a time. But basically, we've got nowhere. Let's look at another possibility. How would it be if we randomized places where there are a lot of old people into programs similar to the SEPA, a protocol-based examination, for example, of how they're finding things, the services that are provided. How's the food? How's the other stuff? How's the care? And who's going to do what to fix it? And got them engaged in that. And then measured the outcomes with cognitive testing and quality of life estimates. Unfortunately, by the time we can get any biological markers, we're already at a point that we're not going to come back from. By the time you've got MRI changes, those are changes. They're not going to change. They're not going to come back. So we put together a trial like this, choosing what might seem like odd places, but the comparison is between Mexico, Australia, and South Africa, where there are very, very different cultural relationships with old people and very different ways of managing and housing them. So let's see. It is, again, the test of what happens in engagement. And our thinking is that what will happen is that this participation in the audit of their care will lead to their increasing engagement, increasing interest, that those 3 little words of executive function will kick up their executive function, and that will provide a better therapeutic environment. We're not saying this is going to vaccinate anybody against age-related cognitive decay, but we do think, and this is the idea, that if what we're talking about here in this communities mobilizing aspect has to do with a corollary of executive function, we might be onto it. Across services in general, I complained about the quality of care and the meaning of true universal coverage. So last year, the Journal of the American Medical Association came out with these figures that were as startling as they were incomprehensible, where, according to their estimate, some amazing number of millions of people die each year, and some quantity of dollars that I have no idea what it means, what $1 trillion is, except they have a lot of them somewhere else. is due to just poor quality of care. If we add to that who is not getting reached by the supposed full coverage of services, what happens? Added to this, we've got this very interesting and I think very positive new thrust in public health, which is that customers are wanting a say-so pretty well across the board. And managers pretty well across the board need a way to hear them and to interact with them. So, adaptive management is a process that we work in several projects where we basically present evidence, we engage stakeholders on the evidence, and we get feedback. We give that feedback into the loop so that those stakeholders land up changing their own process. I mention this just because it's the same thing as we were talking about before. In our own educational processes here, we've become involved in game learning as a way to understand more about what happens if I wanted to work with this group to say, okay, let's look at what executive function means here. What would I do? Well, what we've done is try to develop a series of games and the game learning philosophy that allows us to look at collaborative learning, this governance structure, the balance between my interests and other interests, the evidence, real data, and the possibility in the game of innovation, so a low-risk, low-cost experience. So we're doing this in relation to medical school education, medical student education. We're doing the same thing in relation to one of the outcomes of that vector control program. So I mentioned that we did this very nice, interesting, innovative vector control program. And then we went to the governments of Mexico and Nicaragua and said, look what we got. And they said, so what? And we didn't know what to say next, because they have a machinery, every country in Latin America, most countries in Africa, Canada, has a machinery for vertical control of vectors. Somebody in an office somewhere says, we're going to do this. They hire people, people go out and do stuff, a list of things. That list of things is the link between the bank and their pocket, and they go home. And we're surprised that nothing's changed. Compare that with where people in the community say, this isn't my problem, I'm going to deal with it. How I deal with it is not your business, but I'm going to deal with this. And they do that in balance with the rest of their community or elements of their community, because Mexican community is just a geographic area. It's not people who live the same, think the same, or anything else, but fractions of that doing their stuff. So this whole part is questioning how we learn, and that game, called Game of Zones because it's about the echo zones, is trying to add a premium to participation, to give value to participation in programming. And by training, our hope is by training people who are involved in vector control, that they will get more involved with this way of doing things, and we can maybe influence a little bit their way of dealing with this kind of epidemic. So, last point is that what do we have to work with here? Well, conventional epidemiology statistics doesn't really do it, including the concept in conventional epidemiology that participatory research is small. You can see what we do here is nothing small about it. It's not necessarily all successful, but it's not small. So there's a whole lot of things that we've needed to revisit. You might not see this at the back, but it says stakeholder-led randomized controlled trials. That's an example like the 3 trials that I mentioned here, where you're randomizing a protocol of engagement, a protocol of shared, collectivized executive function. The second, so that's a tweak of a well-standard method, randomized controlled trials, everyone knows about them. The second is called weight of evidence, where what we try and do, and this is the work of Andersson, very good PhD student, try to combine stakeholder opinion, community opinion, service worker opinion, with literature reviews. So that we're not in the situation where the literature review says something and people know another thing, which is very common, particularly in public health. So that's a key part of that is something that we've also got very good at, fuzzy cognitive mapping. You might have heard of this. Very good, very flexible technique. Social network analysis. As we're trying to get to that last 5%, the ones at the back of the queue, the ones who are going to give 80% of the mortality and the morbidity, but who are left out of the refashioned definition of universal coverage, how do we reach them? It's a kind of a glorified snowball sampling, turning snowball sampling on its head and using that same technique to recruit people. That people tend to know people like themselves, and if you can find the edge of the marginalized, you can usually get to them. So we've got quite developed techniques for doing that. Budget modeling. One of the issues about participatory research and participatory actions is that for the government it's free, but for the people who do it, it's not free. How do you take that into account? Because you're asking people in a community to support an entire machinery that doesn't work. Whatever it is, vector control, prevention of, well, everything really. Another brief example is clustering. Everybody knows in conventional statistics, you want to take account of the clustering effect. Take account. We don't just take account. We want to understand the clustering effect. We want to know how much do we get from that socializing of evidence. How much in that pyramid have we managed to get that individual motivation down? What does the clustering mean? What, when I say collectivized executive function, what is the value of that? Because that must be in budgets. And until that's in budgets, all these problems are going to stay, and we're going to carry on chugging along our route of doing the same old public health, and they're not going to, those problems are not going to change. Finally, there's a relatively recent and rather small update of how you get, for example, in that vector control study, how do you get what those people know into your formal statistical assessment? And this is the area of Bayesian statistics, where you can quite easily weight things by what people know. It's a lovely area, beautiful. So that's what